Now to finish off our trio, we have Satya Rao from Spectrum, who is the clinical director of Spectrum and a consultant psychiatrist there. Thank you. I'll do this for you.
Good afternoon. Can you hear me at the back? Thank you. Hope you've been enjoying the conference so far. It's been a really exciting conference. I'm certainly very pleased to be here. And let me start by thanking Jan McMahon and Paul Kamel for inviting me for this conference. My job today is to see if we can find some happiness and in trying to find some commonalities between all the treatments we've been talking about so far throughout the day. I hope to outline the commonalities in the treatment approaches for BPD and also try and describe how common factors can be incorporated into treatment of BPD. Lots of great research has been done in the last couple of decades, and there is, as you heard several times today, a lot of hope and enthusiasm regarding borderline personality disorder. We heard that BPD is a very common mental illness, and the most conservative prevalence rates that's agreed upon is at least 1%. So our search for the cause for borderline personality disorder is pointing us towards a biopsychosocial etiology, which is in keeping with all the other psychiatric illnesses in general. It's also quite clear that borderline personality disorder is an eminently treatable illness. I wouldn't have believed it myself, but I've seen it in my own practice in the last 10 years that patients get better all the time. I keep telling my colleagues that if they don't believe that borderline patients get well, please come to Spectrum and come and sit in our clinical review meetings and see us discharging patients. BPD causes significant distress to our patients, to their families, carers, and their friends. However, I believe it also causes significant distress to clinicians who are engaged in treating them. And this is often less well acknowledged. I believe that we need to acknowledge it so that we could help the clinicians to treat these patients better. The NHMRC guidelines clearly state that having BPD is not the person's fault and that it is a condition of the brain and the mind. I think this statement is very important, and we need to take this to the community because often borderline patients are blamed for their own illnesses. We know that psychotherapy works for BPD, and psychotherapy is the treatment of choice at this stage. Medications are not very helpful. As Catherine Bennett told us this morning, medicines can help but not heal BPD. I agree with Andrew Channon this morning, who said this morning that the last word has not been said on medications, and I strongly believe that one day we will find a medication for borderline personality disorder, and it will take the edge off the significant amount of the symptoms, and then we could do the psychological work in addition to get better outcomes. However, with psychotherapy, we know that the prognosis is quite good for most patients with borderline personality disorder. But there is also significant stigma, as we have heard repeatedly today, and often patients are refused treatments. And unfortunately, in Australia, we still don't have a population-based approach to treat all borderline patients in the country. We often have a very chaotic and fragmented approach. We know that treatment as usual does not work, or as Andrew Channon this morning put it, it is, I forget what he said. He didn't say treatment as usual, he said something else, isn't it? Yeah. But that's what treatment as usual is, what is offered most of the time. Most patients do not get adequate or appropriate treatments, and most of the public mental services are not really geared to treat borderline personality disorder. Now, the mental services, I believe, were set up for managing primarily the psychotic disorders and the major mood disorders, and not really ideal for borderline personality patients. And also, our sector is hugely under-resourced, and we also have a mental health workforce that is inadequately trained in the management of BPD. So therefore, we often tend to medicate patients, admit them and discharge them without really treating them with psychological treatments. So we have significant challenges facing us. As I said earlier on, we know that at least 1% of the population suffer BPD. Now, given 1% of prevalence rates and a national population of about 22 million, we potentially have 220,000 borderline patients in the country. If we were to provide a treatment like dialectical behavior therapy for all borderline patients in the country, we require $1.76 billion. We'll never get that sort of a funding. Now, given these facts, I believe most patients are and will always be treated within the general hospital, general area mental services settings, rather than in very highly specialized services such as Spectrum. Now, if we are serious about organizing clinical interventions for BPD population, we need to really address these questions. What should be the model of care in the public services and for borderline personality? What are the care pathways? See, for disorders like schizophrenia and bipolar disorders, we have a clear pathway. Clinicians, the services know what to do right from the intake till they are discharged. We have secure services, we have mobile support services, CAT teams, inpatient services. It's all, the care pathway is clearly set. But for borderline personality disorder, we don't have a clear care pathway. We don't have a model of care. Do all those persons who attract a diagnosis require long-term specialist treatment such as DBT or MBT? Andrew Channon again asked this question this morning, because if we wait, we don't know whether all the patients require specialist treatments. Are there less expensive and less intensive but yet effective treatments that can be used for borderline personality disorder patients, which can be undertaken by the entire mental health workforce, both in the private as well as in the public system? That's a question. Also, are there generalist treatments that can be undertaken by the current workforce with very minimal additional training? And if we are going to use specialist treatments, what are the situations where specialist treatments need to be undertaken, and for what kind of borderline patients? So I'm not going to take you through the list. This is the list of all the treatments we have, specialist treatments we have for borderline personality disorder. Now, these are a couple of homegrown therapies, the conversation model of Mears from Sydney, and the acceptance and commitment therapy from Spectrum. So totally we have about at least 20 randomized controlled trials in support of the specialist treatments. So there's really mushrooming or proliferation of treatments for BPD. This is very, very encouraging. However, it is also quite confusing, both to clinicians as well as to patients. So therefore, attempts have been made to try and see if we can integrate or if we can find commonalities. So all specialist treatments for BPD appear to be equally effective. So although there is more research for some treatments such as DBT or MBT, so when you really do comparative studies, they all come out as equally effective. No one treatment comes out as superior to another. And there are clearly more commonalities than differences. Now, they all look very similar to each other when you really look at them very closely. Now, these are some of the generalist treatments. And clinicians have always very intuitively found that good quality generalist clinical interventions yield positive clinical outcomes. Now, research is now proving that to be true. In research trials, specialist therapies have been compared with well-organized and skillful generalist treatments. And not surprisingly, it has been found that generalist interventions, such as this list, are strikingly effective and nearly as good as specialist treatments. At least this is true in the context of research. Now, the effective generalist treatments are the structured clinical management, which has been compared with the mentalization-based therapy in UK, and structured clinical management is compliant with the NICE guidelines. Gunderson's general psychiatric management, this has been compared with the DBT, and it is compliant with the American Psychiatric Association guidelines for BPD. The good clinical care, this is a manualized treatment which was developed by the Andrew Channing's group in Melbourne, and this has been compared with the cognitive analytical therapy, and again equally effective nearly. The supportive psychotherapy has been compared with DBT. This is a US-based study by Clarkin et al. When we are talking about effective generalist treatments, we are not saying that generalist treatments are treatment as usual. So by generalist treatments, what we mean is they are well-organized treatments that have incorporated the common ingredients of specialist treatments. And they are specifically developed for borderline personality disorder. Now, further work has been undertaken to examine the common factors in all the specialist treatments and the common factors in all the generalist treatments, the ones which they listed above. So these are all the generalist treatments. People have looked at the commonalities in all these generalist treatments and the commonalities in all the specialist treatments. And the NHMRC guidelines again outlines treatment principles, and international experts such as Bateman, Gunderson, and others have all outlined what they think are the factors which are going to work for people with borderline personality disorder. So these are some of the researchers who looked at the common factors in specialist treatments. Bateman and Livesley have looked at the common factors in generalist treatments, and NHMRC guidelines clearly outlines those principles. Now, let's remind ourselves that NHMRC guidelines says that people with BPD should be provided with structured psychological therapies that are specifically designed for BPD and conducted by one or more adequately trained and supervised health professionals. NHMRC guidelines, they do not specifically recommend a particular specialist treatment. So Livesley has captured the current clinical dilemma which we've been talking about in the following statement. He says, what we need to know is what kind of interventions works with what kind of problems and with what kind of patients. This is really the key question. Now, this is my attempt at summarizing the common factors in all the specialist treatments and all the generalist treatments, the expert opinions, and the NHMRC guidelines. And I believe that most competent mental health clinicians already utilize many of these common factors. However, they need to be structured and systematized within the treatment context. The therapist factors are therapists who are adequately trained in the application of these factors, and therapists who have support and access to supervision, therapists who hold hope for these patients, and therapists who are actually willing to treat these patients and actually choose to treat these patients. And therapists who are enthusiastic, who are active and engaged in therapy, being mentally and emotionally engaged, and those who use appropriate amounts of self-disclosure, exploration, confrontation, problem solving, etc. And those who have a clear treatment model based on a coherent theoretical approach, and therapists who actually reflect on their own practices and responses in therapy. Other therapy-related factors which are common to all the evidence-based approaches are having a clear treatment framework, which is being reliable, consistent, having clear boundaries, and having treatment contracts, and well thought through crisis plans, treatment plans, etc. And having a clear structure if they're in the private practice about cancellations and appointments and cancellation fee, etc. And having a consensus on the goals of the treatment, and taking a collaborative approach and developing a consensus on how to achieve these goals. A strong therapeutic relationship is clearly central and key. A therapeutic approach which is focused on achieving real change, paying attention to the affect, the emotions experienced by the patient as well as the therapist, and helping the patients to recognize and label emotions, and working on distress tolerance skills, working on anger, paying attention to transference, countertransference, etc. Now, other therapy-related factors are exploring, employing the exploratory and change-oriented interventions, that is using behavioral analysis, chain analysis, clarifications, etc. And focusing on patients' mind, not just their behaviors, an MBT concept. Being empathic and taking on a validation style approach, a DBT concept. Having a healthy balance of limits and flexibility, again a DBT approach. And paying attention to crisis, collaboratively developing crisis management plans, and analyzing crisis and sentinel events when they happen, and having an individualized approach to patient care. Now, other factors which are important include organizational willingness and support, and having consensus between the treatment teams. We heard this morning saying that there could be fragmentations between teams and clinicians, and there is lack of communication. It's very important that there is a consensus between all the team players, and again, supervision to therapists and teams, providing psychoeducation, coming up with clear diagnostic formulations, and managing the coexisting disorders such as depression or psychosis or other disorders, and differentiating between the acute risks and the chronic risks. It's very, very vital. Differentiating between self-injury and suicidality where possible, and focusing on improving function. Now, how to incorporate common factors into the treatment of BPD? It's by recognizing that treatment as usual does not work for BPD. Treatment as usual does not contain the essential ingredients to bring about a real psychological change, and treatment as usual can contribute to further deterioration of the condition in some situations, and treatment as usual does not produce holding for the therapist, often resulting in very reactive sort of responses, and recognition that treatment as usual is just managing patients and not really treating patients. And having willingness and enthusiasm of clinicians to undertake treatment, and it requires upskilling therapeutic skills, knowledge of common factors for BPD treatment, and having access to supervision. I keep repeating about supervision again and again because it's really vital. And having thorough treatment plans. And many of these ingredients are already offered, but in a less structured and less consistent fashion. So what do we need to do? We need to continue to increase awareness, such as what we are doing now, influence and educate policymakers and funding bodies, and implement the NHMRC guidelines. It's been out for the last 3 years now. We are still struggling to implement them. And call upon for a national training framework for BPD and declare BPD as a public health priority. It is really time to take a national population-based approach to the care of people with borderline personality disorder. And we need to develop newer model for managing BPD in public mental health services. In conclusion, training clinicians to adopt these common psychotherapeutic factors, they should not require extensive or expensive training. And they offer real hope that we may be able to not just manage or not just do treatment as usual, but actually treat people with borderline personality disorder without imposing excessive demands on resources and within the context of our current healthcare systems. So I'm going to leave you with this take-home message by Zannarini, who says that any reasonable treatment provided by reasonable clinicians in a reasonable manner may be beneficial to people with borderline personality disorder. I just want to end by sharing with you an experience of mine, which is, this is about 10 years ago when I just joined Spectrum as a consultant psychiatrist. I was a trained DBT therapist, and Katrina here would remember we worked together. So I believed DBT is the end of all treatments. If someone is not doing DBT, they're really not, it's not good enough. So I went with that attitude to Spectrum to be proved completely wrong. What I found was that my staff now, they practice psychodynamic psychotherapy, mentalization-based therapy, acceptance and commitment therapy, dialectical behavior therapy, Gestalt therapy, so on and so forth. So when I sat in the clinical review meetings, I found that it didn't matter what they did. They all had similar outcomes. We gave them a 2-year time frame to finish up treatment. At the end of 2 years, all the patients were recovering. Then I started noting down in my notebook as to what were the common factors. So these are all the common factors which has been shown in the research. I am now convinced that the way to go is common treatment principles, and specialist treatments are required. I still practice DBT, and specialist treatments are required for a particular group of patients. But if you are serious about taking a population-based approach and wanting to treat every single borderline patient in the country, we need to look at less expensive and these sort of common factors. Thank you very much. All the best.
Thank you, Satya. It certainly probably resonates that when you practice what makes sense for you, you're more authentic, therefore you're more honest, therefore people see it, and therefore the relationship's better. Yeah, maybe that's the common factor, that you're comfortable with it, so they're comfortable with you.